Hi, everyone. Welcome to the session. My name is Jennifer Cohens, and I'm the Executive Director for the Ontario Prader-Willi Syndrome Association. Thank you for joining us this morning to be a part of our OPWSA virtual conference. We are so pleased to have Cindy Szapacs joining us once again. She's a fantastic speaker. I always love hearing what she has to say, and we are so thankful that she was able to join us again today. So we've got a jam-packed session, and I do want to leave times for at the end for questions and answers. So without further ado, I'm going to hand things over to Cindy.
Hi, thank you, Jen. Thank you all for showing up to come and listen to this. I'm excited to get to talk about this topic. So I know we get a lot of questions and interest about this. So like Jen said, I'm going to be talking today about autism, diagnosing autism when an individual is already diagnosed with Prader-Willi syndrome. Now, I will share, so by trade, I'm a board certified behavior analyst. I've worked in clinics and been on a diagnostic team. I currently, and I'm not able to diagnose, so I don't actively diagnose children or individuals with autism, but I've worked on teams and I'm aware of the kind of the nuances and the differences and looking between Prader-Willi syndrome and autism. So just wanted to put that out there. So on the next slide, we are going to talk about what we're going to talk about today. Yep. So we are going to talk about what are the core symptoms of autism and what are the core symptoms of Prader-Willi syndrome. So first, we're going to separate out the two so we can understand them each separately. And then we're going to look at how they overlap, where there are similarities and where there are differences. We'll talk about what should a good autism evaluation consist of and what you do after an autism diagnosis is made, or possibly if it's not made and you really were thinking it could be made. So why are we even talking about autism when we're at a Prader-Willi conference? So the research does suggest that the prevalence of autism within the population of Prader-Willi syndrome is higher than the general population. So there's some research. The general research, if you just kind of do a quick look over literature, there's not a lot of literature. There's not a lot of research on this topic. Generally speaking, the majority of the literature is done through parent report. And so when researchers give individuals who already have Prader-Willi syndrome, they give their caregivers or they give their parents forms to fill out and rate behavior rating scales. How often does your individual do this behavior or that? So when they're using just the rating scales and parent report, you will find that the prevalence is considered between 25 and 41%, meaning that of people who have Prader-Willi syndrome within that population, 25 to 41% meet the criteria for an autism diagnosis. However, Dr. Dykens did one study where they actually included a multimodal diagnostic evaluation, which included direct observation of the individual. So rather than just relying on parent report and looking at what behaviors are being observed, it was a panel of experts from a variety of different backgrounds, psychologists, speech therapists. They observed the child. We're going to talk a little bit about the tools that they used. And when a really clear study was done with all of those observations and those more specific tools, their data showed a 12% prevalence rate. So when the test was a lot more pointed and specific, the rate for autism was lower. So the rate within that population, again, that's one study, it could be replicated again, but 12% is what showed up there. So that's one reason we're going to talk about it. I know it's a hot topic. Prader-Willi syndrome and autism, the behavioral symptoms can overlap. So there's a lot that looks very similar on the surface when you're looking at autism and Prader-Willi syndrome. So trying to understand, can you tease out which is which? And then if somebody with Prader-Willi syndrome truly does have autism, you may want to look at some special considerations. And also when you're evaluating them, we're going to talk later about knowing this individual has Prader-Willi syndrome, what some of the research shows that you want to take into account when looking at an autism diagnosis, especially some of the speech patterns are different when somebody already has Prader-Willi syndrome. So now we're going to start on the next slide we're going to go and we're going to look a little bit specifics of Prader-Willi syndrome. So Prader-Willi syndrome is a medical diagnosis. I'm sure if you're on here, you're aware, it's diagnosed through a blood test. So we can do a blood test and we can say, yep, this person has Prader-Willi syndrome. I know few and far between there's cases where they do, the methylation and they do that FISH and nothing comes up, but the individual is showing lots of symptoms. They'll get what's called a clinical diagnosis. But overall, technically speaking, Prader-Willi syndrome is a medical diagnosis. We know that the symptoms occur in phases, starting with the failure to thrive in infancy and then changing as time goes on. And we all know that typically the defining feature of Prader-Willi syndrome is that hyperphagia, which can then lead to life-threatening obesity. And there's, some of these common traits that are on here. And for Prader-Willi syndrome, we know that at this point in time, the only specific treatment is human growth hormones, specifically for Prader-Willi syndrome. Even though they're working furiously on finding more, that's all we have right now. So now when we look at autism, we're looking just at autism. So just through the lens, just talking about autism when we're not talking about Prader-Willi syndrome. This diagnosis is made through behavioral observations. So it's kind of like looking at an individual and saying, what does the individual do a lot of? And what do they not do a lot of? A lot of autism is about doing little to no of something, often in the social area. And so the core symptoms when we're talking about autism are in the social communication functioning area. So one of the key categories here when you're looking at autism is while the diagnosis itself can be made at any point in the lifespan. Now that there's been more information about autism, and especially individuals who would have fit in that category of Asperger's when that was still a diagnostic category, there's some adults that are being diagnosed now. But the way the diagnosis is made is by looking back over their lifespan, and were these symptoms present in early developmental period, first 3-4 years. The symptoms that an older child is experiencing now, when we talk to you about what your child was like, 1, 2, 3, 4, were there any concerns there? Did we see them then? And the social communication symptoms need to cause a significant impairment in function. And this is where it gets tricky when we look at the overlap. What's autism? What's Prader-Willi syndrome? Is it truly co-occurring? Or can this be contributed to the Prader-Willi syndrome? Or if this individual also has an intellectual disability, can the intellectual disability be a better account for these behaviors that we're seeing? Or is it truly from autism? So autism itself, there's no medical test. It's diagnosed behaviorally. They use what's called the DSM-5, which includes behavioral observation and developmental history. So at its core, autism itself is categorized by a difficulty engaging in social and communication behaviors. And like I said, it's often characterized by children doing less of things. They may be doing less reciprocal interactions. They may smile less. Little babies, when they're little, just a little baby, they'll smile. A caretaker will smile at the baby and this baby will smile back. That is what would be considered a reciprocal social interaction, just to go back and forth. They're smiling back and forth. Autism is also characterized by just not using toys in the way they're supposed to be designed. So someone with autism may roll the wheels of a car instead of pushing it. So this is the diagnostic criteria. This is what you'll find in the DSM-5 that people, psychologists, developmental pediatricians will refer back to when looking at the symptoms of autism. And so as you see, like I kind of summarized, the first one talks about persistent deficits in that social emotional reciprocity, engaging in interactions with adults. This is not about the physical act of talking. So while people with autism, a common characteristic is they may talk later. Some may not develop the ability to talk, or they may develop a limited repertoire in talking. The talking itself is not a diagnostic part of autism. It's definitely a red flag. If a child isn't talking, really talking by the age of 2, that's a red flag to look into this. But it's more about communication. It's more about a child may not be able to talk, but they can communicate. When a little toddler wants something, they're at the parent's legs, pulling on their legs. They're not talking. They're pulling on your leg. They're pointing. They're looking at you. They're using gestures. They're using all of these things to tell you what they want. So it's about the interaction and the relationship between two people, not the physical act of talking. And so if somebody is not able to follow a point, so some common red flags early on would be, a toddler or young child that doesn't use pointing to communicate or doesn't understand. So if you point, can you go back, Jen, to the previous one? Thanks. So if I point to something and they don't follow my point to look, then that would be a red flag as also. And then when they're looking at the diagnosis, they're going to specify severity. So this is all about social interaction. I know, for example, so I do have, my son is almost 15 and he has Prader-Willi syndrome. And when he was a toddler, he used a lot of sign language, and he would get himself over to the front door and he would look at the front door and he would look at me, and then he would do this, which is the sign for eat. And he would do this, which is the sign for out. Not one word was exchanged, but a variety of nonverbal communication happened there. So that's what you want to see. If you don't see a lot of that, that's a concern about autism. Individuals with autism also will engage in restrictive or repetitive patterns of behavior. I know this is often common. People with Prader-Willi syndrome will talk a lot about, the same topic frequently. So this is also the area where when people think of Prader-Willi syndrome, they often think of the hyperphagia. When people hear autism, they often think of the repetitive patterns of behavior, such as hand flapping or lining things up. So it's just one piece of the diagnostic criteria. It's not the only one. And this can also occur with other disabilities as well. So the presence of this could indicate a concern about autism, but if there's good social interactions going on, then, it could be something else. Okay, now we can talk about joint attention. So joint attention is key. This is a key area when you're talking about autism, and what really defines it from other developmental disabilities. So joint attention is when two people pay attention to the same thing for purely social reasons. I do not want anything from you. So in this interaction, we have this picture here. It looks like they're out hiking, and you can see everybody's looking somewhere. The little baby's pointing. That baby is pointing. Maybe they see like a big bear, they see a cool bird. That family is enjoying an interaction together. That baby saying, look, and then the parents are looking, and they're all communicating to each other for the fact of just communicating and enjoying that interaction. That baby's not saying, hey, get me that bear. I don't want that bear over here. It's literally saying, just look what I see. I want to enjoy that. I want to enjoy this interaction with you. So this behavior, this joint attention behavior, typically will occur in children as young as 12 months of age. Just that 3-point gaze. So when an airplane flies overhead, you get the 3-point eye gaze. You look at the mom, the kid looks at the airplane, and then the child looks back at the mom, purely to communicate, hey, this is cool. I want to share this experience with you. So people with autism will often communicate, if they're going to initiate communication, which is difficult for them, they will often communicate to get something to meet a need. They want to eat something, they want a toy, or they want to tell you to get away. Communicating to share an experience is going to happen a lot less often. Now, all of these symptoms that we're talking about, there's interventions for. So, a young child who may not display joint attention skills initially that leads to an autism diagnosis, through intervention, they're going to be, that's going to be part of the intervention, helping them understand that people are valuable and people are interesting, and we can share experiences together. So while you look at a diagnosis, and I'm talking a lot about all of these things that these individuals are not doing, it doesn't mean that they don't have the ability to learn, because they do. And so that's why it's important to get a diagnosis as early as possible so that the right interventions can be put in place. So now on the next slide, what I'm gonna do is kind of summarize a little bit. So we've seen Prader-Willi syndrome, right? So we see the symptoms that are specific to Prader-Willi syndrome. We know the hyperphagia. We know early on there's a failure to thrive. The research has shown, so there's the skin picking. So SIB stands for self-injurious behavior. And people with autism may also engage in self-injurious behavior. But when research looked a little bit more specific at the types of self-injurious behavior that people engaged in, when you do they did a look at all the Prader-Willi syndrome research, people who had only a Prader-Willi syndrome diagnosis, the SIB they saw was the skin picking. Whether it be wherever on their body was the skin picking. So skin picking was specific to Prader-Willi syndrome. And then additionally, they also found that people with Prader-Willi syndrome, they just had a hard time forming their thoughts, getting the thoughts out. So when Dr. Dykens, they did their research, and they had a group who just had Prader-Willi syndrome, a group who just had autism, and then they had a group who had Prader-Willi syndrome and autism based on all of their research that they did. Within that group that ultimately ended up having Prader-Willi syndrome and autism, before they made the final decision, there was a subset within this group. So there was a subset of individuals who had Prader-Willi syndrome that on the surface and looked like they had autism based on the communication deficits. But clinically, when they really looked like they had the communication deficits that would lead to an autism diagnosis. Parents felt like they probably had autism. Without looking really closely, it was looking like they were going to get a dual diagnosis. But when they fell within the range of autism in this test called the ADOS. So that's Autism Diagnostic Observation Schedule. And that is what's kind of considered the gold standard when you're looking at an autism diagnosis, ADOS. That is the shortened version of it. So when these individuals with Prader-Willi syndrome were administered the ADOS, they came up within range of being at risk of having autism. But when they looked closer, and a speech therapist looked closer, what they found was that their communication deficits were not related to the social piece. It wasn't that they weren't trying to communicate, and that joint attention piece, that social piece was there, but the act of talking was really hard for them. So these individuals ultimately ended up getting an apraxia diagnosis. They were reaching out, they were communicating, but because of the apraxia, the motor piece was hard to get the words out. So that was a really interesting piece I thought I found in the research, because if an individual has speech apraxia, there's a really specific intervention that you need to do to address that. If they were just kind of looked at on the surface and said, yep, there's some communication needs, they have Prader-Willi syndrome, they have autism also, the intervention is different. And the apraxia would probably have been addressed as well as it should have been. So it's really important to understand where this communication piece is coming from, the underlying cause. Is it a social communication piece, or is it a motor communication piece? So that's why it's important to have this multimodal piece. So now we can look at autism and just autism on its own. So these are the symptoms that are unique just to autism. Now, notice that the first bullet talks about significant impairment in social communication skills. It can't just be, every now and again, it's a little bit, it kind of gets in the way. You really want it to be significant. And it's the social communication piece. That's the heart of autism, that social piece just not coming natural for whatever reason. Again, that hits that joint attention that I talked about earlier. And a small portion of children who have autism may go through a period of regression. Typically, that will happen in the first 3 years of life. So there are reports of children who had developed play skills, or they've developed some communication skills, they've developed words and they're talking somewhere in the first 3 years. That starts to go away. Parents talk about them. They used to say all these words and now they don't say any of them. Or they used to play really well with cars. We used to line them up and we used to spin them around and have a lot of fun, knocking over blocks with the cars. And now they just want to sit and spin the wheels. So that's just in a small piece of it. Um, Another feature that was identified in research that was specific to autism when you compare them to PWS was the presence of the stereotypic behavior. So stereotypic behavior is what some people will call like self-stimulatory, when we think of maybe hand flapping or walking on our toes. So by definition, stereotypic behavior is body movement that's repetitive in nature. And this can occur in many forms, and it may or may not include objects. So some examples, like I said, would be the hand flapping or the body rocking or maybe waving strings in front. So that feature, those stereotypic body movements were found specific to autism. That is a common autism trait. Now we're going to look at the overlap. So how do these two overlap, since they do tend to share? So according to research, which I said, there's not a ton of it, there's not a lot of it, but according to the research that's out there, these are the behaviors that are shared by both diagnoses of examples. So while people with Prader-Willi syndrome will show some impaired social skills, which is also a common deficit in those with autism, it's important to remember that when administered the ADOS-2, many scored below the threshold for autism. So again, on the surface, we found that somebody with Prader-Willi syndrome had some social skill deficits, but then when given this ADOS-2, which looks specifically at autism symptoms, they scored lower. They didn't meet the criteria for autism because those social impairments weren't significant. They were probably more like mild or moderate. So that's where that significant piece comes in. So Prader-Willi syndrome and autism, they share an insistence on sameness. Both of the people with those diagnoses, whether they have comorbid diagnoses or just one, just Prader-Willi, just autism, they're going to want to follow their routines. They may want to wear shorts year round and not change because it's gotten colder, or they may want to wear the same pair of shoes, even though they're 3 sizes too small now because they like things the same. Restricted interests you'll see between both of them. And that can be anything. I know currently my son is very, very, very interested in doing Peloton workouts. And actually it's lasted for a good long time. And I'm not really, it's a good type of obsession to have. He likes to do his workouts. He likes to check in and have them on the schedule, but he also can talk to you about that all day, all the time, about the different workouts he's doing. So the interest can vary by individual, but both diagnoses share that common symptom. When you're talking about language, so that reciprocal language, that back and forth, I say, hey, how are you? Good morning. And then, he says back, Peloton workout. Not super reciprocal. We want to get that hello, good morning. What are you doing today? And then you could answer Peloton workout. So reciprocal language, that back and forth is difficult for both diagnoses. Understanding social overtures, that ability to read a room, is going to be difficult for both. Social cognition, just because I love talking about and doing Peloton workouts, doesn't necessarily mean, understanding that doesn't mean everybody else does. So if I love it, it means everyone else must love it. So that ability to kind of take in that other people aren't going to love the same thing or not like the same thing. And that goes with the perspective taking. Both diagnoses may engage in tantrums for, various reasons. A lot of times because of that top bullet, something being changed, not being done the way they want. And both diagnoses will show some, often some form of language delay. So now we're going to talk about the evaluation itself. So if you're concerned that your child may possibly have autism in addition to Prader-Willi syndrome, or if you're just interested to see if your child's behavior meets the criteria for autism, because I know, and we're going to talk a little bit about services, because there's a certain service maybe, and it's being denied because autism is not on their file. I know, now I live in Pennsylvania, so I'm in the United States, and here, applied behavior analysis, which is a great intervention and is not specific to autism, insurances have decided that you have to have autism in order for them to pay for that service. So while lots of people will benefit from ABA services, and if somebody can afford to pay for that privately, they can get that. It's very expensive. If they want to get that service and the child has autism, then insurance will pay for it. And I know that in Canada, there are some similar, and at the end, Jen has a resource to share with you guys, because I know that that autism diagnosis will open up, windows. So if you're thinking, oh my, I can definitely see some of these symptoms in my child, I would be interested in these services. Let me see if this is applicable. You want to make sure that you have a comprehensive autism evaluation. So what that means is that, first, the evaluation should consist of more than a parent completed checklist. So like we talked about I talked a little bit about that early on. There's a variety of checklists, and they're good to do quickly. You can do them with the pediatrician. You can go online and find them if your child's young enough. Some of them are only for the age of 2 or 3, and there's some that are older. So you can fill out these checklists just to see if there really are risk factors. But again, they rely solely on parent report. Jen, you can click through to the first. Yeah, there you go. Thanks. So they're not meant to be diagnostic. So if you go in saying, hey, I want my kid looked at for autism, and it's just a quick thing where the doctor does a little checklist with you, and then that's the end, that's not considered a complete diagnostic. That can be part of it, and it's a good way to screen if you should go further. So, because they can be administered quickly, and they can, identify, and some places, if an individual is considered at risk, will start doing a little bit more services. And if you're considered at risk, then you want to go further for additional testing. So this testing should include direct observation. This is the part in the research from Dr. Dykens that was really, really important in teasing out the subtleties of if autism truly exists, or is there maybe, that apraxia, is it more of a motor speech piece than a social speech piece? That's really important to know. So as I mentioned before, the ADAS-2 is commonly used autism assessment, and that really looks at social communication opportunities. It's play-based. It can take 20-ish minutes to administer. It's fun. Someone has to be trained in it to do it. But it's not one of those grueling sit at the table type things. It's fun, play-based type assessment. Again, this should not be the only thing, only the ADAS itself, because again, in that research, some children with Prader-Willi who showed a score within the range of autism ultimately didn't end up with an autism diagnosis given other factors. But you want some sort of direct observation looking at these social communication skills. And then you also want this evaluation to also include developmental and medical histories. You want to look at adaptive functioning, cognitive and behavioral functioning. Again, like I said, have a speech therapist involved, have an occupational therapist involved, just to rule out that there aren't any motor pieces that are the barrier for getting this social component out. Is the motor piece the barrier, or is the social piece the barrier? So now on the next slide, we're going to talk about who can diagnose autism. So again, it's recommended that you want a multidisciplinary team to do this. So while a pediatrician technically can write a script with an autism diagnosis on it, and that, that will be honored by an insurance company or somebody who needs that, it's not recommended or considered, the multidisciplinary assessment. So completing an autism checklist with a pediatrician is a great start. And oftentimes, I know at least around where I am, the wait list to get a good autism diagnosis can be months. And so the checklist is a great way to start, because it may be able to veer even the treatment that you're doing. If the child is coming up at risk, you can tell, the people working with your child, and they may start working a little bit more on the social piece if they haven't been. But you don't want to stop there. So some pediatricians are certified and can administer the ADAS-2. So you can ask that question, and your pediatrician could do that as well. And that, that would help. And you just want to make sure that you include a speech therapist, because you want to consider some of those speech-based factors that I mentioned earlier. and that speech therapist part is just so important, because we just want to make sure, again, that the motor piece isn't what is putting this barrier up. So now, what do you do if an autism diagnosis isn't made? And I know a lot of people, this can be a tough time. So some people, it seems to be, are seeing their child and saying, I really think there's something else going on. Interventions aren't being successful. My child's not making great progress. I really think they might have autism. They go in, they get the evaluation, and a diagnosis is made. And for those people, it's kind of actually like relieving, like, okay, I have my answer, because we've been doing all of this stuff and it just wasn't working, or I've just felt in my gut there's something more. And so actually this additional diagnosis for them may feel like, okay, like this makes sense to me. It opens doors for me. It's going to get these services I need. There, for sure, are other situations where people go in, and sometimes I know individuals aren't even looking for an autism diagnosis. They're just there at the doctor, they're seeing their developmental pediatrician for a yearly follow-up, and well, I think maybe we should talk about autism. I think your child may have this, also. And it's like, bam, it's like totally out of the blue. This is really surprising. It's a shock, you're going to probably go through all of those grief stages again, because here's a second diagnosis, kind of the world is crumbling. And I do want to let you know that if that situation happens, it is, it's going to be a shock. It's going to be hard. It's not going to be easy. It's never easy to hear something like that. But if it is true, it's going to open the door for your child and for you to get some services that, and even to just change the current intervention. You may not need any additional services, but it may be like, oh, we need to veer our focus a little bit more this way now that we know that this is a little bit more of a problem. And so that it's still the same child you walked into that appointment with. You're still going to keep doing what you're doing, but now you're going to be equipped with additional information to help your child even more. So I'm sure there's plenty of people that will go through, all those grief stages again, but I just want to let you know that all of these symptoms that we've talked about, there's intervention, it can get better. So the earlier, the better. So now you're one of those people that went in, you went in and nope, we're not giving your kid an autism diagnosis. And you actually wanted it. You wanted that relief. Maybe you wanted to go to that ABA clinic. So what do you do now, right? So first, review the report. Ask lots of questions. Don't feel embarrassed. Don't feel like you're bothering them. That's what they are there for. You are the parent. You need to understand what that is. If you don't understand the language, if they didn't have a debriefing session with you, you get that. You get your questions answered, because that may help. You can always get a second opinion. If you got your questions answered and you just didn't feel like questions were answered, you just weren't happy with the way they were answered, you didn't feel like the evaluation was comprehensive enough, maybe it was missing the speech therapist input, or you felt like the observation wasn't there, or the observation wasn't there at all, go ahead, get a second opinion. That doesn't hurt. Continue with your services. So just continue advocating, continue what you're doing. If you feel like, if you were one of those people that was looking for, say, ABA services or a social skills group, I know some social skills groups will limit the diagnoses they allow in. Go ahead and call that group back. Make your case, see if you can get your child in there. Prader-Willi syndrome is a lot more rare than autism. It's going to be really hard to find a Prader-Willi syndrome specific social skills group. And if all you can find is an autism specific one, and everyone's feeling like that's what your child needs, go ahead and, this is what he needs, and see if you can get him or her in there. Just continue to keep an eye on the symptoms that you were concerned about, and then consider a reevaluation later. If you keep an eye on it, you still see the symptoms, they're still happening, consider another evaluation. There is some support in the research that the autism symptoms become more obvious in those with Prader-Willi syndrome. It comes more obvious later in age. And so if you took your child when they were younger, go ahead and try again, when they're older. It's still seeing these symptoms, it's still a concern. maybe lack of progress. I'm not sure if they're not seeing progress, that could be something, and then go back and go run through it all again. And when you're looking at the services, you also can consider, appealing to your insurance. Also, possibly, if your workplace has any say over what the insurance covers and doesn't cover, you can go to human resources and make a case for why they should maybe add certain things. But just keep an eye on things and see how it goes. So here's some things to know about an autism diagnosis. So a medical diagnosis and an educational classification are different things. And definitely, I know in the United States, and I think it's somewhat similar in Canada, that at least for us, if I have a script that says autism on it and I bring it to a school, it doesn't automatically qualify for anything, because we need to make sure that the symptoms and the behaviors we're concerned about are interfering with the ability to learn. And so if they have some symptoms at home, but it's not interfering at school. So, and there's different criteria when you're looking at, medical and educational classification. And you can choose who you want to share this information with. You can choose, if somebody gets an autism, if your individual that you take care of gets an autism diagnosis and you don't want to tell people, you don't need to tell people. That's your information. That's, your privacy. So just because somebody gets an autism diagnosis, you don't have, you choose who you want to share it with. Now, if you're going to want to, if you end up sharing it with, say, school personnel or a therapist on the outside, insurance companies, other doctors, it can open the door for more services. So if you've gotten this diagnosis by surprise and you're feeling really uncomfortable about it, once you start to see that maybe this, you get a second opinion and you feel like this really is a valid thing, sharing it with other medical professionals, sharing it around can help it'll open the door, for more services, and it can help tailor the way instruction is being delivered currently. It may not need to add or take anything away. It may just tailor a little bit, pinpoint what you're going to do. Because we know that Prader-Willi and autism share a lot of similar behavioral characteristics. So I'm sure we're all aware that with Prader-Willi syndrome being so rare, it can sometimes be hard to get the appropriate services or to get what we really need. And so if an autism diagnosis is made, and you're not so sure how you feel about it, but if you can kind of realize, oh, this is going to help all of us in the long run, you can just tell people who need to know, the insurance company maybe that needs to know, but you don't have to go around sharing it, with anyone that you want. And the reason that there's a lot more out there for the autism is just that's where more of the research is. Like I said, there was very little research even on the comorbidity of the two, so more needs to be looked at. And then I just want to share some of my sources here that I use. These are the different, the different websites, the different articles that I reviewed. I did speak with Elizabeth Roof about this because those of you who know her at Vanderbilt, she's a researcher at Vanderbilt, does a lot of behavioral research in Prader-Willi syndrome, and also works with some of autism and diagnosing autism and looking at that specifically. So I did speak directly with her, get some information about that between the two. So I want to thank her for that. And then if you are interested in autism, there's an Autism Speaks link. And then, the PWSA with the Prader-Willi syndrome link. So I want to thank you for your attention, and I'm sure if we have any questions or comments, I'm happy to answer them.
Thank you so much, Cindy, for the wealth of information as you always provide to us. It was really interesting to listen to. And before we go into some questions, I did want to highlight a couple of things in terms of the Ontario, Canada context. With the autism diagnosis, it can give you the exceptionality with respect to the IPRCs in schools. So for those of you who attended our education session yesterday, we talked about IPRCs as well as exceptionalities that would perhaps lend you to different types of placements and things like that in schools. So autism is one of those criteria for the exceptionality. I also wanted to highlight the Ontario Autism Program. This is run through the government, and I provided a link which will be attached in the slide deck as well. And I also provided the eligibility criteria, but essentially you could be eligible for additional funding through the Ontario Autism Program. And we all know additional funding is great to have. So make sure that you take a look at their page and find out more information. You do need that assessment or written diagnosis in order to be eligible for it, but it's a great source of additional funding. Sorry, what's that?
That's really nice.
Mm-hmm. Exactly. I also wanted to highlight Autism Canada, and I don't have a slide for that, but I will add it in before I send it out to everyone. Autism Canada is another nonprofit organization that's huge. We know autism has way more numbers than, say, Prader-Willi Syndrome does. So if you're looking for specific resources related to autism, they would have a family support coordinator. I was just on their website that you could reach out to find out more specific details around resources related to autism and potentially also, assistance with diagnosis and things like that. So they would be a really good resource for you as well. And I'll be sure to include their information into the slide deck before it goes out to everyone. So just to get us started with the questions and answers, and I'll remind everyone to please go ahead and enter any questions you have into the chat window or Q&A pod, and we'll do our best to address everything that comes through. But I know we've given you a lot to mull over. But one question I had to start was, how would behavior management look different, if at all, with a PWS and autism diagnosis? So if you get that dual diagnosis, how might that
So
change?
From my perspective, as a behavior analyst, it doesn't change a ton. It's actually the Prader-Willi Syndrome diagnosis that has a lot more caveats to it when looking at intervention, like not using food as a reinforcer, the prevalence of stress and anxiety and how that can affect behavior, that type of thing. And if you're looking at it from the other way, first Prader-Willi syndrome and then autism, it may change because, again, people hear autism, they immediately say you need ABA. And that's not all. There are individuals with Prader-Willi syndrome who receive ABA services, but if it's a situation where they're not, the intervention may look different because an ABA provider may be brought in, or say maybe a teacher or a therapist may say, oh, let's start using these principles. Even though the principles are applicable to people with and without a diagnosis, that's kind of what happens. But the principles themselves are the same, but I think once people know for sure it's autism, they may be a little bit more specific and systematic about it, because that's what the literature says we need for autism.
Thank you.
Mm-hmm.
This was a really interesting topic that when I was speaking with you about coming and speaking at our virtual conference, you had actually volunteered as a potential topic that we could discuss. I was curious, what made you want to explore this topic?
Yeah, that's a good question. This is something that comes up a lot. Like I see it a lot because I'm on the Facebook groups, and I have local friends and families, and it comes up a lot where people are just kind of asking questions like, is it autism? Now here, I should have done a little bit more research, but I know here we have some classrooms that are specifically they're called autistic support classrooms, but any diagnosis can go there. But it just means that the intervention is a lot more looking at the social communication piece. And that's what I do in my 9 to 5 life is consult in these classrooms. And so our focus, because we know social aspect is a difficulty, our focus is on building up that social repertoire. And then, not so much on the ABCs and 1, 2, 3s per se. And so just looking at if autism really is a core deficit here in Prader-Willi syndrome, it's really hard to tease out the two. So which is which? Is this something we should look into? And then, of course, like I talked throughout the whole thing, it opens up doors for services. And so it's that question of, well, I know my child has Prader-Willi syndrome, and I know they're going to have social issues because that comes with the disorder. But now I'm getting kind of turned away from things. Could there be something more? Could it be more than just Prader-Willi syndrome? And it can be both. So I just found it interesting to kind of look at the two and to empower people to understand like what a real evaluation is. Because a lot of people do kind of sit down with a checklist in 10 minutes and walk out the door. And it could go either way. They could maybe not get a diagnosis because, parent report is different than an expert report. And then I know as parents, we learn to like tolerate and live with a lot. And so as we're filling out a report, we're filling out a survey, we may not see certain things because we've already learned to modify our life to anticipate their needs. My kid doesn't have temper tantrums, or yeah, sure, my kid has social communication. I don't know, but it's just that I'm anticipating. I know what they want to eat, when they want to eat, and I know their favorite shirt. So they don't even have an opportunity to engage in that social communication stuff because I've anticipated it. And so I may report, nope, no problem. But then you sit down and you do like the ADOS, which is systematic and has all of that built in. So, the tasks and the tester is doing things to elicit the individual to initiate social. So for them to be the one to start it, and it's set up that way to look at really closely. And so parent report, not just parent, just surveys in general aren't super accurate. And so making sure people know to ask for that piece. And then I really found the part about the apraxia and the speech apraxia I found really interesting, that subset, 100% of that subset all ended up with speech apraxia. So to really look closely at the communication deficits, and are they communication or is it social? Because like I said, the interventions are so different. And if someone truly has apraxia and you're not doing the apraxia methods, you're going to make little to no progress. And so you want to make sure that you're really addressing what the issue is. So just because it's so muddled, try to help people figure out what's what.
Thanks.
Mm-hmm.
I just wanted to add in, and we have one of our board members who is a former educator, and she's listening in, and she
Nice.
led our education session yesterday. She just sent a message to let us know that here a student needs an autism exceptionality in order to be placed in an autism class. And we do have those sorts of autism specific.
That would be another benefit and I don't know if those, I know here those classrooms are definitely run a little differently, like a learning support room versus an autistic support room, or there's a reason they're called different things because they're going to meet different needs. So I would assume it would be similar, with the emphasis being on the social. So that would definitely be,
and certainly specialized teachers.
Yeah.
We do know of those in our community that have gone that route with some autism background and things like that.
Yeah, so that would definitely be a benefit to go and get that, just to have that option. Even if you decide that's not the route you want your individual to go, you at least have the option there.
For sure. Okay, so there is a question that came through the Q&A, and I'm just reading it now, so bear with me. But the comment and question is, my daughter has both PWS and ASD diagnosis, and I find that the services available just don't fit my daughter's behavior. For example, she won't interact with her peers, but can interact almost normally with adults. So social groups end up being a competition for the facilitator's attention.
Oh, interesting. Okay, yeah, that's pretty common across both, and then definitely the adults. And so that's the kind of the other presentation I've done a couple of times about how when you've got somebody with Prader-Willi syndrome that enters a situation that's typically autism, the things that kind of need to be changed or molded a little bit. But yeah, you would just want to look at, that's also a common issue in people with autism though as well, that people with autism, younger people with autism interact better with adults. I think it might a little bit be more about the predictability and the control, like you can predict adult's going to answer you, adult's going to be nice to you. I cannot predict what another child's going to do. And they may or may not want to talk about what I want to talk about. And it's just not fun for me, but the adult part is more fun. So I guess you just have to look a little bit closer at the interventions and the reinforcement. And beforehand, I'm not sure, like how much talk between like the parent and the facilitator, or if there's an option to just do like smaller groups, so there's less, just maybe dyads, the person who wrote in her child with the other child, and then that would be a little bit easier to control. I do know that people with Prader-Willi syndrome, I think generally tend to do well with rules and kind of setting goals and kind of wanting to please. And so maybe looking at some sort of like setting a goal, like today we're going to talk to a friend 3 times or something. And then over time building that up. And so kind of the motivation piece for talking to the friend, or even looking at what the other peers have. If there's a certain toy, like for example, like I said, my son likes Peloton. So maybe if we had that issue, I sent him into a group, I might send in a bunch of like Peloton stickers or something that we've gotten in a package, and have the other people have the Peloton stickers on, which would then motivate him to maybe want to talk to them, because it would be about something I'm telling you, he knows what that P is, and he goes right up to people. And it's actually been a really like interesting, good social thing for him, because everybody these days seems to be obsessed with Peloton, and it's pretty age appropriate. So he'll run up to anyone, oh, do you like Peloton? And they're like, I do, who's your instructor? And he can go back and forth. So it's pretty cool. So maybe thinking about whatever that is for your child, and is there a way to implant that to the other, or have that be the topic for that lesson, to try to motivate more interaction there.
Great suggestions. Thank you.
Sure.
So I know we're getting close to the end time, and we'll still give a couple of minutes in case folks have any other questions coming through. But in the meantime, I'm going to run through a couple of last slides, as we're waiting for any additional questions. So first, I'd like to let folks know that we are running our Cheers to Charity raffle fundraiser. It's a really great campaign. It is $10 a ticket. We have 1,500 tickets printed. The grand prize is $1,000 worth of gift cards to a store of your choice. And these are all, it's from a list of stores. We have, I think, about 10 or 12 stores on the list, but it's all kind of big name stores that you can find anywhere, like Best Buys, Costco, Loblaws, that sort of thing, so that you can use your money, your gift cards there. You can also choose the denominations that you would like for your gift card. So let's say you won the $100 worth of gift cards. You could choose whether you wanted one $100 gift card, or 2 $50 gift cards, or 4 $25 gift cards, so that you can share the wealth. So if anyone's interested in being a part of our Cheers to Charity campaign, whether it's either purchasing tickets from us or helping to sell tickets on our behalf, please contact me. We are doing very well with our sales and are going to be running out of tickets soon. So if you're interested, please make sure you contact me sooner rather than later. I also wanted to let everyone on the call know that we do have a virtual dance party later this afternoon at 4:30 p.m. It's for individuals with PWS and their siblings or supporters. It's a really fun session. It's led by an instructor where she's encouraging different sorts of movements. So it's not just, you have to be a dance expert or anything, but she plays music and will walk people through, okay, make your arm circles, make them bigger, and that sort of stuff. So it's a really great way to exercise as well. It's free. So if anyone's interested in participating in that, please go to our website and register.
My son did it last year and he loved it.
Excellent. Yeah.
He's all ready to go tonight. He loved it, dancing around the dining room. He thought it was great.
Thanks for that, Cindy.
Yeah.
So hopefully we'll see some of you guys there later tonight. And I do want to thank Cindy again for being here, joining us, sharing your expertise. I always love hearing what you have to say. And I think this is a really interesting topic that we as a community in Ontario, we hadn't presented before. So it was really, really great to hear about, and I'm already seeing some great feedback in the chat window as well. Before I let you go though, we did have another question come through. So another challenge is my daughter's profiling of her facilitator. If she doesn't like the facilitator or instructor, she won't engage. If I sign her up for a program, she may refuse to participate regardless of her interest, and how to make that that intervention more successful.
That's a multi-faceted. I will say that kind of idea of making up, that's common Prader-Willi Syndrome mindset. I'd say sometimes about either like someone or you don't like someone. So I know personally, and just kind of if it's a situation that your daughter's never been in before, I try to reach out to the facilitator prior and say, these are the things that are going to make it successful, because if the first session isn't successful, it won't be successful. So kind of, if you know, like these topics, this way of interacting, this way of talking will help. I guess the other thing is across the board, if it's difficult to get your daughter to cooperate across the board, or if it's just this one thing, if it's across the board, then it might be looking at the interventions that are being done, throughout the day. Because if it's difficult to cooperate with something simple, then it's also going to be difficult to cooperate, say, going out and for a skill that's hard for them. So I think there's like a lot of different, I unfortunately don't have a quick fix, but it would just be looking at, the style. And if there's any way to get your daughter involved in the choosing of it. I know sometimes when I build things up, so if you can build it up and also make her feel like she's in control of the choice and what she's doing, that will help with the buy-in. So if you've decided like this is something she needs, or if there are two things that you're not sure about, go ahead and let her make the choice. Or if there's one that you really want, it's kind of like you build it up and you talk about it for days before, and then it becomes, or you talk about this and then all of a sudden, oh, you build up the idea of the group, and then it's like, oh, look, I just got this email about a group and we were just talking about that and this would be great. And maybe that's how, that's on the front end though, before you start something new. It's a little bit more difficult, and it's going to actually be working with the facilitator more than your daughter. I think if it's been a relationship that's already been established, that's a little harder.
I think it's a great suggestion though about that pre-reach out to say, here are the sorts of things my daughter likes, and you might win some points by mentioning these sorts of things. So that's
exactly the general rule of thumb with Prader-Willi syndrome is about prevention rather than intervention. So anything we can do to prevent the later problems from, you're going to be way more successful, because once they happen, it's a little harder.
For sure. Well, we are at our end time, and I don't want to take too much of your time because you've already done so much for us. But I, again, wanted to thank you and thank all of our participants for joining us today. We really hope you enjoyed the session. I'll be sending a follow-up likely next week, because today's jam-packed with the AGM and the dance party and everything. But I'll send a follow-up with the link to the slide deck, and I'll let you know when the recording's available on our website as well, and may ask for some feedback on the sessions as well. So thank you again, Cindy, and thank you to all of our participants. Hope you have a wonderful day.
Thanks everyone for coming.
Thank you.